I'm very glad to be with you, Zindel. I'm uh, 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 really appreciate the opportunity to have a conversation with you about the special institute that you're going to be leading for AGPA. It's scheduled for Friday, February the 19th. It's part of our new virtual format that we're utilizing this year. And I appreciate the opportunity to ask you some questions about the format, about what you plan to teach, and very much looking forward to what's going to be a spectacular event. So the first question, tell us a little bit about where you are, what you do, and then we'll talk about the Institute.
Sure, Molyn. It's great to see you again and to have a chance to interact this way. Um, I'm a professor at the University of Toronto in Scarborough. I'm a co-developer of mindfulness-based cognitive therapy and a researcher who's published books and really, I would say, has tried to introduce and provide some evidence for the use of mindfulness meditation in the care of people with mood and anxiety disorders. And the way that we've done that has been through randomized clinical trials and research on mechanisms, on neural findings, supporting affect regulation capacities, but most of all, also training people in a very intensive experiential way. And then I hope that some of that is going to get communicated in the Special Institute itself.
That's great. That's great. I'm familiar with the work, with the science, the research. I know some of the original work showed very powerful effects in helping people maintain wellness in the face of recurrent depression.
Mhm.
Uh, I want to ask you some questions in terms of what other populations uh, is this mindfulness-based cognitive therapy, mindfulness work particularly useful for?
Yeah, that's a good question. Mindfulness these days is such a big term and it's used, I would say, even bandied about almost carelessly, both inside the therapeutic community and outside of it. And, my own reaction to its use therapeutically is to be a little bit more conservative. The best evidence that we have is that it's effective for depression relapse prevention. There's also good evidence that it's effective for people who have residual depressive symptoms, even though they've achieved a significant level of remission. Sleep may still be disordered, they may still have anxiety. So it's very good in reducing residual depressive symptoms. It also seems to have a very strong evidence base on anxiety. There are people who have recommended using it for depression itself, but I'm not convinced that the data are really strong enough to say put first line psychological or pharmacological treatments on the side and use mindfulness based cognitive therapy instead. I don't really agree with that. But people are trying all kinds of things. I think more generally, though, the value of mindfulness meditation is that it can teach very generic affect regulation skills that aren't confined to people that have a mood or anxiety disorder, but maybe engaged in other kinds of problems that they're trying to help themselves with.
So there's a broader applicability for this work in helping people improve reflective capacity, modulate emotional distress in general. Is that fair to say?
I think it's fair, and I think that it's increasingly backed up by scientific evidence. I have to remember mindfulness meditation and the whole concept of meditation itself initially is a spiritual pursuit from the East that has been brought over to the West in the context of enhancing healthcare options for people, wellness, resilience, these kinds of things that people are looking for. And um, in understanding what the mechanisms are by which meditative practice can be helpful, it's increasingly clear that it is supporting the kind of metacognitive abilities that people can develop for themselves to observe their experience, to watch their experience, not to be fully identified with their experience, and then to be
Mm.
able to choose to be less reactive in ways that might be less habitual, less triggered, less reflexive, and that this can occur in a wide range of problem areas.
Do practitioners have to, uh, uh, do people have to have a personal practice in order to be able to deliver this kind of intervention?
Well, You're talking to one of the co-founders of MBCT, so the answer to that question for me is yes. But I'm not saying it in a doctrinaire kind of way. I'm saying it because my own journey
Mm,
into this work started with my not having a practice
mm,
and noticing how ineffectual I was at a point where I was facing affective moments with patients, but not able to really prescribe or understand how mindfulness could be used in suggesting ways for them to help themselves. I could fall back on my own therapy skills and alliance and cognitive therapy and other approaches, but I couldn't recommend anything from inside the practice of mindfulness until I
mm,
myself had a practice.
mm. Okay, that's very helpful. In what kind of clinical settings uh, can this mindfulness based work be applied? Because I'm imagining there's lots of instances where people will get a kind of introduction or a lighter exposure to it than the full bore.
Yeah,
Uh,
yeah.
so, what other applications are you aware of, or would you recommend? Can it be used in inpatient settings, for example, with patients who are admitted for psychiatric illness?
Yeah, I think that this is some thing where creativity, clinical flexibility is really going to uh, be expressed in ways that are going to be helpful to patients. I think as a starting point to learn the 8 session program, or to learn about the 8 session program where a lot of these practices are embedded is an important foundational place to start. But then what people have done is that they've taken elements of that program and adapted it to their particular population. So one of the things that we do in mindfulness-based cognitive therapy is we teach something called the 3-minute breathing space,
Mm,
which is a way of allowing people to um, ground themselves and to notice, reactivity or notice ways in which their minds might be moving ahead of them, either in preparing for a difficult event or after they've had a difficult encounter with someone. Something like that can be taught in a number of different ways in individual therapy, inpatient treatment, without having to go to the full model.
mm,
If the person doing the teaching themselves understands what this is and how it can be utilized alongside other uh, straightforward clinical interventions. Another thing that can be very helpful is the use of mindful movement or movement of the body in a way to help settle the mind. That
mm,
can be used and recommended in a lot of different contexts. I think the important thing is the therapist who uh, peppers that into their treatment also needs to check up and see how it's landing with the patient. Is it
right,
something that the person is interested in doing? Are there compliance issues?
right.
It moves away from a narrative-based form of treatment. All of these things are really intriguing. They're also really great moments for creativity.
Hmm, hmm. That makes a lot of sense. A couple of other questions.
Yeah.
What is the value of delivering this in a group as opposed to individual? How does the group add or complicate or make easier or make harder the work?
It's interesting. We initially developed this as a group intervention, not because we were smitten by the principles of group psychotherapy, but because we thought it would be the most cost-effective way of delivering it for a disorder as prevalent as depression. But having practiced it and delivered it and taught it over a couple of decades, it's clear to me that the group context itself adds a lot to the process of first of all allowing people to settle in. People often who may not be in the midst of very severe levels of symptoms, but who may be coming in with a sense of shame, a sense of stigma, a sense of inadequacy, and seeing other people like them in a group for similar reasons can be very powerful in normalizing their capacity to learn from each other and practice. So I think there's that. We don't really, I would say, amplify the group process to help this material be more easily learned by participants. We practice together, and usually the exchanges are one directional in the sense, or yeah, they're one directional in the sense that they're between myself, if I was the teacher, and a patient, rather than a patient and other patients or participants in the group. It's almost
Uh-huh.
frowned upon a little bit. So I'd say that there are ways in which the group certainly amplifies and helps, but there are also ways in which this deviates, or I would say maybe steps away from the traditional forms of group therapy.
Hmm. So I'm imagining, though, you still try to make use of the feeling of universality, the feeling of group cohesion, connection, the presence of peers, uh,
Yeah.
without a focus on interpersonal interaction. But
I would say without interpretation of interpersonal interaction for sure.
mhm,
A lot of the bedrock beliefs about meditation is that we all have the same mind.
uh,
So universality shows up in the way that people see their minds moving away from and being distracted by and wandering and judging. It all shows up in the same way. And as that happens, people can see a sense of common humanity. We also, when the group comes across material that we're discussing that brings a lot of negative affect into the room,
mm,
that's acknowledged, that's faced, that's a there's space that's allowed for that.
I
And I
see.
think the group, in a sense, can learn from that as a way of approaching affect. But a lot of it is demonstrative rather than interpretive.
Great, great, very clear. Last question,
Yeah.
Zindel. In terms of what can people expect in terms of the way in which you plan to use the day, how you teach, how what kind of approaches can people expect?
Um, this is challenging, but at the same time, I think it's also context that we can use to our advantage. My teaching of this material really emphasizes helping people to get a good didactic foundation of the rationale for doing this, because presenting this to patients sometimes can be a little bit challenging if people need to understand why or what this can do for them, the evidence base behind it. And then having provided that, I think we drop into the practice itself,
Mm,
the practice of mindfulness, and then do that together as a group. And my inquiry into that practice would be very much online with what I would do if we were a group ourselves. And so my thought for this institute is to have us work as if we were a group for the first half, going through the practices, getting the feel of what it's like, and then seeing if we can work in small breakout rooms
uh-huh.
with each other and with oversight. I wouldn't call it supervision, but at least a chance for me to visit and sit in on some of these groups as people try to teach us one of the simple practices like a 3-minute breathing space
I see.
or a guiding practice. So folding that all in together to give people a sense of what this actually is from the inside.
That sounds great. I'm really excited that you're going to be doing this.
Yeah,
I'm registered for the special institute you're going to be doing, and I look forward to that very much. Thanks
yeah.
so much, Zindel, for making time for this interview, and look forward to seeing you at our meeting.
Thanks, Molyn. Thanks for asking me.